Good afternoon, everybody. We'll be getting started in the next minute or so. While you're waiting, just mute your microphone and turn off your video. All right. Good afternoon, and thank you for joining the Primary Care Innovations webinar series, which is supported by the H. James Free Center for Primary Care Education and Innovation. My name is Ryan Nall, and I'm Associate Director for the Center. Before we get started with today's presentation, I wanted to take a few moments here just for a few housekeeping items. As I noted as you came in, please mute your audio and turn off your video. We're recording this session and we'll have it posted on our website, primarycareinnovations.cme.ufl.edu. If you'd like to view this webinar or any of our past webinars, you can find them at that link. If you want your face or audio to be part of our video recording, you're welcome to leave those on, but I'd recommend turning them off. Any questions that come up during the session, please type them into the chat. I'll be moderating a Q&A session at the end, and we'll go through those questions at that time. To claim any continuing education credit at the end of the session, please complete the evaluation of this webinar after it is complete today. And finally, next month, on September 18th, we'll have a presentation by Kimberly Castillo, Dr. Luisa Echeto, and Dr. Denise Sintrup on an innovative project in nursing and dentistry partnership. And certainly welcome you to join us next month for that topic. Today, we're thrilled to have Kelly Lykos, Isabel or Izzy Walker, and Michelle Nall from the University of Florida's Mobile Outreach Clinic. They will be presenting Reproductive Justice and Contraception in a Safety Net Clinic. Michelle is a nurse practitioner with the University of Florida Mobile Outreach Clinic, where she provides primary care and reproductive health services to the underserved community of Alachua County. She's board certified as an adult health nurse practitioner. Most of her clinical experience has been in innovative community-based primary care settings with vulnerable populations. She's especially interested in improving access to sexual and reproductive health services for low-income and uninsured women. Kelly graduated from the University of Florida Masters of Public Health program this past May, and she began volunteering at the Mobile Outreach Clinic in May of 2019 as a care coordinator, and in August of 2019 became a Research and Quality Improvement Chair of the MOC Advisory Board. As Kelly progressed through the MPH studies, she became a graduate public health research intern for the Mobile Outreach Clinic and specifically focused on contraception access and educational initiatives through the clinic. This fall, she'll be working at Emory and coordinating their COVID-19 vaccine trials. Izzy holds a Master of Public Health from the University of Florida as well. She started volunteering with MOC in January of 2019 and has co-written multiple grants for MOC specifically to support MOC's Reproductive Justice Initiative. This fall, Izzy will start her physician assistance program at Emory University in Atlanta. Thank you for joining us today and sharing your innovation.
Let's get started. So we are staff and volunteers with the University of Florida Mobile Outreach Clinic, and we're going to be talking today about incorporating reproductive justice into a contraception and reproductive health initiative in our safety net clinic. My name is Michelle Nall. I'm a nurse practitioner. My training is as an adult health nurse practitioner, but I have had a lot of experience with reproductive health, working in a Title X clinic in Alachua County, and now helping to build the infrastructure for more robust sexual and reproductive health services here at the University of Florida Mobile Outreach Clinic.
My name is Izzy Walker. I was a care coordinator with MOC throughout my MPH. I also served as a Spanish interpreter. I did my internship while I was at UF getting my MPH with MOC, and now I'm a first-year PA student at Emory University.
And my name is Kelly. I was also a care coordinator throughout my MPH at the University of Florida, as well as the Research and Quality Improvement Chair for the Advisory Board, and then an intern for the Reproductive Health Services at MOC for my internship, and I'm now living in Atlanta.
And we're very excited and honored to be able to present this webinar today and talk about some really exciting things happening not only at our clinic locally, but some conversations that are happening nationally in the arena of sexual and reproductive health.
So just to start off, we want to acknowledge that not all persons who have the capability to become pregnant and give birth identify as a woman. We use the term woman to remain consistent with cited literature, and patient to describe persons seeking sexual and reproductive health services who have the capability of becoming pregnant. So this is something that we are looking on expanding in our clinic, and that we have some initiatives to try to improve our inclusivity in the clinic setting, and we're going to talk about that a little bit more later as well. So for the overview of this presentation, we're going to explain a little bit about our setting, which is the Mobile Outreach Clinic at UF, as well as how access to sexual and reproductive health services is currently in the United States. We're going to discuss the role of long-acting reversible contraception, which we'll commonly refer to as LARC, and the evolution from a LARC-first approach to a reproductive justice approach. And then we're going to talk a little bit about how we've built a reproductive justice initiative at MOC.
So the University of Florida Mobile Outreach Clinic is a flexible means of delivering healthcare to medically underserved individuals in low-income neighborhoods around Gainesville, Florida. The clinic got started in 2010, so we're about 10 years old, and right now we serve 5 neighborhoods in Gainesville that have been identified through hotspot mapping, areas where there are higher rates of uninsured individuals, areas where there are higher rates of multiple health disparity outcomes that we look at. And our goal is to really meet patients where they are. So we, our clinic is actually situated on a renovated Bluebird bus that we bring out to these neighborhoods. We have regular clinics in each neighborhood, and serve primarily uninsured patients who tend to have low income and who, for whom other medical services are prohibitively expensive. Our populations, as I mentioned, are uninsured and underserved citizens in Alachua County and surrounding areas. We really aim to be a completely low barrier clinic. In other words, people don't have to jump through a lot of hoops to get our services. They can literally show up. We meet them where they are, both literally and figuratively. We provide really robust primary care. So we're constantly wanting to increase our level of care to match that of what a person would receive in a more traditional bricks and mortar setting. So we do a lot of chronic disease management. We offer sexual and reproductive health services, which is our focus today, including things like contraception management, preconception and some basic prenatal care, HIV and STI testing, evidence-based cancer screenings. We can do basic lab work, and we are increasingly partnering with other departments within the University of Florida to offer specialty clinics as well. So we actually have a regular radiology clinic who performs ultrasounds for our patients. We have a regular neurology clinic and a clinical psychologist that volunteers with us as well. And you can read our mission and vision statements here. In addition to all the services I provided, we are a service learning site for medical and PA students here within the College of Medicine. So we also have a hand in teaching the next generation of medical providers about care of the underserved and social determinants of health. So this is just sort of a brief timeline of some of the reproductive health services that we've offered. I mentioned our clinic got started in about 2010, and prior to 2016, and I think like many clinics, our focus and the focus of what we were able to offer at that time was largely short-acting contraception methods. So things like just prescribing birth control pills. We have always stocked Depo-Provera on the bus, which many patients like to use. But in 2016, we started to form the infrastructure to be able to offer free long-acting reversible contraception at our clinic. At this time, that was largely through the use of patient assistance programs, which we'll talk about more in this webinar. And these programs, unfortunately, have quite a lag time. So it involves the patient applying for a particular device and then waiting for that device, waiting for approval of that device, and then it would get shipped to our clinic, and then we would be able to schedule the patient several weeks later for insertion of that device. And at that time, we did offer minimal prenatal services to people who did not have access to prenatal care elsewhere. Around this time, and really for the decade prior, the focus in the United States has really been on LARC first, and these are well-published guidelines that we're going to discuss in greater depth here. And our clinic, like many clinics, have focus on really counseling that acknowledges that LARC is the most efficacious method on the market, and that it has very few contraindications. And our focus around that time is really LARC as the sort of the ultimate method, and everything else as being discussed sort of in relation to LARC. In 2019, we embarked on and are still embarking on an IRB 01 approved survey where we are asking women at 3 underserved clinics here in town, so not just mobile outreach, but 2 other clinics, on their needs, desires, and past experiences with contraception. And we are constantly in the process of writing grants to be able to stock various methods of birth control so that we can basically have the infrastructure to offer women receipt of their desired contraception on the day that they request it, and to not have that lag time. In 2020, and sort of mirroring a national shift in a conversation, we have been moving toward more gender-inclusive counseling during medical visits, more training for our providers and our students to be more inclusive of a variety of populations of people who seek care at our clinic, as well as really incorporating principles of the reproductive justice movement into our sexual and reproductive health services. We are also very much in real time working to improve our preconception and prenatal services and coordination of care for underserved women who are planning a pregnancy or who are pregnant. We'd like to provide an overview of what sexual and reproductive health services look like in the United States. So first and foremost, it's important to understand that while many of us traditionally think of the discussion of contraception or the sort of the national and political discussion about abortion having to do with sexual and reproductive health, it really encompasses so much more than that. This table on the left of the slide here kind of demonstrates all of the services that are encompassed in sexual and reproductive health, and that most women are going to require some of these services throughout their lifetime. The other figure here that we share is it demonstrates who is it that's getting services for sexual and reproductive health and where are they seeking those things. And what we're seeing is that increasing numbers of women in general, and particularly increasing numbers of women who are less than 100% of the federal poverty line or within the 100 to 250% of the federal poverty line. So in other words, people of relatively low income are increasingly seeking these services at safety net or publicly funded clinics. And that encompasses a variety of clinics from Title X to nonprofits, to health departments, to FQHCs. But the idea is just that increasing numbers of women are seeking these services within the national safety net system.
In this next slide, we want to talk about it keeping in mind the limit that using unintended pregnancy as a factor when gauging reproductive autonomy or freedom has. There's a lot of new literature discussing this, but as we can see based from some of the literature that we do currently have, there is a significant disparity when it comes to which communities are having higher rates of unintended pregnancy. The rate, even though the rate has stayed around 50% for several decades, we see that the rate is highest and actually increasing among lower SES women, racial and ethnic minorities, and younger women, while it's going down among middle and higher income women. So that is a current issue that we have. And unintended pregnancy, the next slide, does have a number of deleterious sequelae for the parent, child, and society at large. They can lead to poor outcomes, like physical and mental and physical outcomes for the well-being of the child. Like it can lead to preterm birth and low birth weight, which itself has a number of deleterious sequelae. And in the parent, they've been associated with higher rates of like maternal depression. The parents might be less likely to breastfeed. So it's still an important factor to talk about, but keeping in mind that it has some limitations when we're looking at reproductive autonomy and freedom in general.
So in terms of our clinic and what we've been working with, when we talk about long-acting reversal contraception or LARC, we're mainly looking at the IUD and the implant. So for the IUD, that can include the copper or hormonal option, and this causes endometrial suppression and changes in cervical mucus, and the effects occur before implantation. So this is one of the highly effective methods, as well as the implant. And this is a single rod contraception, and it's quickly and easily inserted and removed. It's discreet as well as highly effective, and is approved for up to 3 years. So these are the two methods that we're primarily looking at. So when we talk about why LARC, a lot of the studies that are well known come from the Contraceptive Choice Project. And this is a project out of St. Louis, where they had a high study population with women ages 14 to 45. And this was from 2007 to 2011. They reduced all barriers to access contraception. The patient was allowed to choose whichever method that they wanted to participate in the study. And after being given all of the methods through a contraceptive counseling session, 75% of participants still chose LARC. So these methods were found to be more than 20 times effective than non-LARC methods in this study.
So if in the safety net clinic and setting, if a patient does want LARC as their chosen contraception method, having a protocol that includes same-day insertion is extremely important because it reduces the barriers to LARC usage that is associated with multi-visit protocols, which in turn can lead to reproductive autonomy, especially for our socioeconomically disadvantaged patients that want LARC. Having a multi-visit protocol is difficult because they might have to balance asking off of work again. They might have to find a sitter for the children if they already have some. Transportation can be an issue if they have to come back to clinic, and those associated co-payments with a second clinic visit. So this is why, if LARC is the chosen method, same-day insertion is considered best practice by the American College of Obstetrics and Gynecology, and why it's something that we really want to implement at our clinic.
For those of you who may already be providing LARC or are considering providing LARC within your own clinic, I want to speak briefly about some of the clinical aspects related to same-day insertion that have traditionally posed barriers. You know, there are really outdated clinical practices that sometimes lead to delaying insertion of a LARC device. And some of these barriers have historically been clinical, and some of them have been administrative, but many of them can be overcome in a setting where this idea of same-day insertion is prioritized. So as previously mentioned, you know, ACOG recommends same-day LARC insertions as best practice when a patient has chosen that as their desired method. And there are really relatively few contraindications to be able to insert these same day. We do see some outdated protocols that require a negative gonorrhea or chlamydia testing prior to the insertion of an IUD, but best practice guidelines do state that in the absence of overt signs or symptoms of a cervicitis or a pelvic infection, that gonorrhea and chlamydia testing can actually be done at the time of insertion. So there's no need to delay an IUD insertion to wait on gonorrhea or chlamydia testing. Additionally, it is, of course, extremely important to rule out pregnancy prior to insertion of an IUD or implant. And there are well-documented guidelines on basically excluding pregnancy with reasonable certainty. This is available on UpToDate and in multiple contraceptive practice recommendations that you can refer to reasonably exclude pregnancy in the patient in front of you and determine whether it's safe to insert an IUD or an implant the same day the patient requests it. Most of the contraceptive counseling has been in the last decade. Certainly, the conversation has been dominated by LARC and by this idea of tiered contraceptive counseling. So these are Spanish and English tables that I actually have laminated in my practice that are adapted from the World Health Organization, but can be found on Bedsider, which is a wonderful patient-friendly website that is free and open access and available to anybody who's interested. So this basically demonstrates the virtually all of the methods that are available on the market today. And it demonstrates them in tiers based on their contraceptive efficacy. So this is not to say that efficacy is the singular focus of every patient sitting in front of you, but I think that this table really shows a good kind of place to start in your conversation with a patient. And again, this is something that we use in our clinic and certainly recommend using to others. It sort of helps explain or put into perspective the relative efficacy of various methods of birth control. As I mentioned, the last 10 years have really been dominated by this idea of LARC first, and appropriately so. I mean, we know that LARC is the most efficacious method of birth control on the market. It's low maintenance, it can be inserted and then basically forgotten about until the day a patient wants it out. It is generally safe and well tolerated and tends to have fewer hormonal-based side effects than you might experience with more short-term methods like Depo or the pills. And so what I want to demonstrate here is just the myriad resources and articles and movements over the past decade that have really encouraged clinicians to discuss LARC first and foremost, and then consider every other method as sort of like a secondary or afterthought. And we're going to talk a little bit about how that idea of directive counseling is shifting on the national scale. But again, I don't want to discount the data that does support LARC as the most efficacious method. So you can see here, we have articles even suggesting LARC may be a key in reducing poverty. We have excellent guidelines from ACOG, Colorado, actually offers free or affordable LARC to the entire state and has some really interesting data coming out of there. So the list just goes on and on. Like I said, this has really dominated the national conversation on contraception for the last decade. However, in real time, we are seeing a shifting conversation toward ensuring that the successes of LARC do not lead unintentionally to coercive or directive patient counseling. And this is particularly important for groups that have historically been marginalized or have suffered sexual or reproductive health abuses. And that idea is the framework for what is known as reproductive justice.
And that's why at MOC, we're really focusing on using reproductive justice as our framework. We really want to center our patients, our most marginalized patients, and use that as the foundation for how we provide care. The literature shows that, unfortunately, in medical education, reproductive care might get like one lecture, and then LGBTQ+, like how to provide inclusive LGBTQ+ care might get another lecture. Then how to provide like racial and ethnic minority appropriate care might get another lecture. If they get a lecture, almost like undocumented patients aren't talked about. And we want to break away from this idea that a white, cisgendered, heterosexual patients are the norm. And then when we get a patient that doesn't identify like that the provider has to pivot, or public health research has to pivot in order to provide inclusive care for that patient. And this is an amazing quote by Loretta Ross, and she's one of the founders of the Reproductive Justice Framework. And it says that all fertile persons and persons who reproduce and become parents require a safe and dignified context for these most fundamental human experiences. And part of Reproductive Justice Framework is really looking at the history of reproductive abuses and understanding why the person in front of you in that clinic setting, or even from a public health research perspective, why they're making the health behavior choices that they are making. And in order to do that, we have to understand their community and generational traumas that they carry with them on a day-to-day basis, and the intersectional oppressions that it comes being a marginalized, part of a marginalized community. And some of this history of reproductive health care, unfortunately in the United States, stems back from our period of colonialization and slavery. We've had coerced and forced sterilization. There have been welfare policies that punish women for illegitimate motherhood. Like if somebody is on government assistance and they get pregnant, they would have a forced sterilization and get their government assistance taken away. The Hyde Amendment, which denies federal aid to poor women seeking abortions, but yet if someone's on Medicaid, they would pay for sterilization. And a long history of coerced and forced use of contraception and LARC, especially among the immigrant and indigenous women population, which is why it's important to understand, again, these generational traumas and why some patients might not want to talk about LARC or have LARC be their method of contraception. And this idea of reproductive justice, again, comes from in the 70s, Black women that were trying to have a more inclusive discussion when Roe v. Wade was coming about. And if you want to learn more about Sister Song, it's the nonprofit that kind of stems from that group of activist women. And Loretta Ross is one of those really important advocates, and she wrote a book called Reproductive Justice, which is an excellent read. And they have a webinar. If you just Google reproductive justice webinar, they have a really good webinar. And so again, back to this idea of reproductive justice, the main definition is that everybody has a right to maintain personal body autonomy. And this includes a right to have children, a right to not have children, and a right to parent the children we have in safe and sustainable communities. Because back when reproductive justice was born in the 70s, the conversation really centered on this idea of choice, like the choice to have an abortion. And it didn't, the conversation on like, well, marginalized communities and parents sometimes didn't have that choice, and choice is really marred by the access to resources that one has, which is why we needed a more inclusive definition. That's why it combines kind of these human rights and social justice philosophies. It demands sexual autonomy and gender freedom for every human being. That goes again beyond this discussion of pro-choice and abortion. And again, the call to action is really to just center our most marginalized patients and to pay attention to the importance of addressing these intersectional oppressions. And that's why we're kind of moving away from, we are moving away from this LARC first approach to really focus on a patient-centered shared decision making model, especially when it comes to contraception counseling. So it is patient-centered shared decision making. It's the blend of informed choice counseling and directive counseling. So an informed choice, it really prioritizes patient autonomy. The counselor or the provider tells the patient about all the methods, how they all work, and then the patient picks. And in directive counseling, it encourages the patient to use the most effective method. So the provider takes on a lot of these assumptions of what would be best for the patient, and maybe what their past experiences were with different methods. And this is why shared decision-making is the best. It's an evidence-based method that sees the patient as the expert in their needs, their preferences, their past experiences, their cultural preferences. And then it sees the counselor as a provider, as the expert on the clinical information that takes all of these needs and preferences and takes into account with contraindications, efficacy rates, important side effects, And together as a team, they come up with the best method that is for that patient.
So for our MOC Reproductive Justice Initiative, we have 3 main aims. And that first aim is to build an infrastructure that allows for the same-day receipt of the desired sexual and reproductive health service by improving clinic flow and sustainability. And then our second aim is to increase patient self-efficacy and reproductive autonomy by providing education and access to reproductive health services using our reproductive justice framework. And our third aim is to train the next generation of healthcare providers to better understand the historical and social context that influence the health behaviors of their patients. So this is a graphic that shows the model that we're working with at MOC. And we have started by creating a beliefs and perceptions survey to be able to talk to our community members and our patients and see what they want to see from our clinic as far as services go. And another way that we're trying to assess patient input is through a patient advisory council. So that's something that is being started to get a wide range of patients to give us feedback on things that they would like to see change or see implemented at our clinic. And then from those two kind of information gathering methods, we have branched into 4 different projects. So the first one being the same-day insertion protocol for LARC. So how can we improve clinic flow to be able to give our patients the service that they desire on the same day that they come in and request it. And then our contraceptive counseling training program. So that's sitting down with patients, going through the different methods available and entering into that shared decision-making model with them to see what they would prefer for their needs. And then our patient contraception education materials. This is something that they can view in clinic and then take home with them to help refresh their memory later. It also links to more resources that they can do more research by themselves as they want, as well as a way for them to contact the clinic if they have any concerns that they really want to talk to us about. And then our last project is the improvement of our preconception and prenatal services, and we've been calling this the pregnancy packet. And this is really a highlighted information that may be useful for our patients. And we'll talk about that a little bit more later. So for our survey, it's about 18 questions, and this is ongoing, and we want to assess desires, beliefs, and past experiences of our patients with contraception. And the demographics include age range, ethnicity, gender identity, insurance status, household income, and education level. And we ask about their current and past contraception use, as well as utilizing the 1 key question framework, which is just 1 question that states, do you want to become pregnant in the next year? And we ask participants how they would access contraception if not for one of the clinic sites. And we also are questioning from them what their gender identity awareness is and how we can best utilize that in our clinic. So this is an example of one of the set of matrix questions on our survey. And so these are some of the things that we want to know what is important to our patients about contraception. So we ask them to rate each of these characteristics based on what is most important to them to be receiving out of their contraception. And then this one is a similar matrix, but we want to know what their beliefs are about LARC. So we're asking them these kind of myths and misconceptions to see what they have heard about or what they believe in terms of side effects with LARC. And out of that matrix, we began realizing that there was a pretty significant educational disparity in what patients were believing about myths and misconceptions. And that was leading to a lot of stress and confusion with our patients. So we wanted to implement this educational debrief to be able to talk through some of these myths and misconceptions with our patients and kind of provide an education about what is true. So we determined that it was best to have this educational debrief for certain pieces of information from the questions, like, will it make your period go away? Will it decrease fertility later in life and stuff like that, to be able to talk through.
And in addition to the survey that is ongoing, where we're looking at what our patients believe and desire related to this, we are also in real time putting together a patient advisory council. So what we're hoping to do is have a council of perhaps 5 to 10 patients that represent different populations of the clinics, the sites that we serve in Gainesville. So we're hoping to have a couple of different patients from each site who come from different neighborhoods, who have different racial, ethnic identities, and vary in ways, but that are representative of our patient population as a whole. Right now, we're thinking that this group may meet twice a year or quarterly. And the idea here is to have patient input on our clinic policies and practices, in the hopes that that this can kind of really help make sure that the policies and practices we put into play are not just us sitting in a room thinking that this might be best for the patient, but rather really hearing their voices and understanding what services they feel like they're lacking or what they're wanting. As mentioned before, part of our reproductive justice initiative is improving access to the same-day receipt of the patient's desired sexual or reproductive health service. Some sexual reproductive health services, traditionally, it's quite easy to get them the same day that you want them. Again, as I mentioned earlier, some that even in the most robust settings, people tend to have to come to an appointment with their provider and go through like a counseling or an appointment where they talk about getting a LARC device, and then that device has to be ordered, and then they come back for receipt of that device. And that's what we see, certainly most commonly across the country in both settings that serve insured and uninsured patients. Our goal is to be able to insert these things when a patient has identified that this is the right method for them, and assuming no clinical contraindications. Our goal is to provide that insertion the day that they ask for it. Some of this is low-hanging fruit, just making certain aspects of our clinic more efficient so that when the patient gets to the provider, there's time to actually do the insertion. So for example, we're putting insertion kits together for faster procedure times. We're not having to get a whole bunch of different equipment from multiple places. Where we have an insertion kit there and available. The patient-centered shared decision-making model is something, Izzy's going to talk about that shortly, where we're actually training undergraduate students to be able to engage in this decision-making model, so that a lot of the counseling related to contraception actually occurs before the patient has even seen the provider. We are working on a product grant for where we would hopefully be the recipient of donations of various LARC devices, and being able to have those in stock in our clinic will certainly allow us to be able to do same-day insertions. We continue to use patient assistance programs for intrauterine devices, and although these do have lag times, some of the patient assistance programs are becoming a little more user-friendly in that they're making the rules a little bit more lenient and being able to sometimes stock up on some devices to be able to allow for these same-day insertions. But we are, of course, always looking for funding to be able to stock these devices in our clinic.
So our contraception counseling program started from this goal of being able to provide the method that the patient wanted the same day that they came to clinic. And it started with, like, well, let's get our CCs to be able to talk to the patients, like Michelle said, while the provider might be with another patient, just talk to them to see what kind of method they want. And it kind of grew from there to really trying to, we're a service learning site to educate our undergraduate pre-health students and maybe even our med and PA students to really understand what reproductive justice is, to really understand how to center their most marginalized patients, and to really understand the power dynamic that happens in that clinic room. So we really framed this contraception counseling program around reproductive justice. Again, another definition, it's the human right to maintain personal bodily autonomy to have children, to not have children, and to parent the children that we have in safe and sustainable communities. So all of the modules that the CCs learn have this underlying theme through it. The primary aims is really to improve sexual and reproductive health, clinic flow, and sustainability, and to empower providers, care coordinators, the medical and PA students and patients to increase our community's reproductive autonomy. And the care coordinators that go through this training are 4 or more semester care coordinators. And the next slide goes into...
I want to just jump in for a quick second to provide some context on care coordinators. So CC is the acronym we use for care coordinators. And these, as Izzy mentioned, this is like a pre-health undergraduate student who commits to volunteering with MOC for several semesters and who in their traditional role provides kind of basic case management and social determinants of health screening, connecting with resources for our patient population. And this contraceptive counseling training would be an additional training that selected care coordinators who have had experience with us are able to go through. Forgive me for jumping in, sorry, Izzy.
So the program was also modeled after our Spanish interpreter program, where they have to do this training and then they have to pass an assessment in order to be able to actually provide the counseling in clinic. The training is a 7-module PowerPoint, and then I'm going through the PowerPoint with them and kind of providing like a lecture style session. For my special project, I created this contraception counseling session flow sheet, kind of like a choose your own adventure, where the patient would show up at clinic and they'd say that they're interested in contraception. And then somebody hopefully a care coordinator at that clinic would have done the training, and they can sit down with the patient, take however long the patient needs, and go through this sheet with them. It asks very specific questions like what the reproductive goals are. That way we know we should focus more on short-acting or long-acting methods. It teaches a care coordinator how to reasonably exclude pregnancy. It talks about important contraindications for things like estrogen-based methods. And then we go over patient-centered informed preference, which is more of an open-ended question on the flow sheet. It has all these specific maybe like side effects or things that are important for the patient when it comes to like what they want in the birth control and what they don't want. We also ask past birth control methods that they've used, what they liked and didn't like about it, with the hopes that in the end, the counselor and the patient together come to a method that's best for the patient. The counseling, the program, the training, also we created a chart template for the clinic notes in order to kind of make clinic flow faster for both the care coordinator and the provider. And the assessment is an in-person written exam. There's standardized patient encounters or like case studies. And we put everything into the EMR so that everything could really be quickly, they could get to it really quickly in clinic so it doesn't hold up the clinic flow.
So another aspect of this training model and how it interacts with our patients is the creation of contraception education materials. So there is one of these sheets, as you can see on the right side of your screen, for every method of contraception that our clinic offers. And it summarizes all of the notable information for our patients and what they might be curious about or concerned about when starting a new method. So this also can direct patients directly to reputable sources. So in the bottom corner, you can see I've put in the Bedsider link and the Planned Parenthood link where they can research more about their method if they would like. And this is just one way that we're trying to enhance the patient-centered care and enhance the reproductive autonomy for our patients to find out more information as they see fit. And then we also, if our patient has a concern, and they really want to talk to someone about it, down at the bottom we have directions for how to call our clinic and how to request to be put through to a provider so that they can address these concerns with the provider or schedule an appointment to come in and address them in person. And this just allows for standardization and program sustainability. These are accessible to the coordinators who go through this training, and this is something that can be printed out and given to every patient to take home with them. And then another initiative that we worked on is the pregnancy packets, as I mentioned earlier. So this is just a one-stop shop, a big folder for our patients to have access to learn about resources in our community. So that can be WIC, or the RN Home Visiting Program, and Healthy Families. And then we also include instructions for how to step-by-step apply for Florida Pregnancy Medicaid. And then there's some educational topics for pregnancy health for both the baby and the mother. And then we also are able to give out free prenatal vitamins with each of these packets. And so this kind of highlights a health literacy consideration, and we also include all the materials in both English and Spanish so that we can reach the majority of our patients.
An aspect of the pregnancy packet that we are in the process of making more robust is the way that we're able to serve women who don't have legal immigration status in the United States. So in Florida, women without legal immigration status are ineligible for pregnancy-based Medicaid. Virtually everyone with legal status is able to get pregnancy Medicaid, at which point we would provide whatever necessary care coordination is needed to help connect a patient to an OB provider locally. However, women without this status and who are going to not be able to access pregnancy Medicaid, really in Alachua County don't have a very robust options for prenatal care. And so one of the things that we are really in the process of working on in real time is making our services more robust in terms of what it is that we can offer for prenatal care. Of course, there are some limitations being at a free clinic, but working with local OBGYN providers to provide support, their knowledge base and consultation if needed when we are seeing women who, for whom MOC is going to be their only source of prenatal care. So what we hope we have conveyed through this presentation is the shift that our particular safety net clinic has gone through over the last 5 years or so, where we're really trying to balance increasing access to all services that a person may need in the arena of sexual and reproductive health, balancing that with a reproductive justice framework, a framework that seeks to educate our providers and our students and those who encounter our patients on the history of reproductive abuses, on cultural competence, cultural humility, and the best way to approach both population and patient-based care. We utilize many resources in doing that, and those are resources that we want to share today. So kind of wherever you're at in your particular clinic, whether you're in a traditional clinic, a safety net clinic, you see uninsured or insured patients, the bottom line is that contraception tends to be one of many things that we talk about in a visit, or I should say reproductive health is one of many things we talk about in a visit. And it can be useful to have really high yield websites or resources at your disposal to be able to help make the best decision with the patient in front of you. And so for that reason, we want to share these resources that we find really valuable. Bedsider is an excellent website that has both a patient and a provider section. It's very user-friendly. It has fact sheets that you can print out for patients. It is very body positive, and it really has a lot of like patient-centered education on a lot of the common concerns that people might have related to different issues for contraception. The One Key Question campaign is an excellent campaign out of Oregon. We mentioned it earlier. It basically what it hopes to do is to encourage all primary care providers to ask one key question annually of their patients who are capable of becoming pregnant in childbearing age years. That one key question being, would you like to become pregnant in the next year? This is an open-ended, non-judgmental question that's a great jumping off point for a discussion on preconception health, contraception, if the person doesn't want to become pregnant, or anywhere in between. We mentioned Sister Song, which is the collaborative of women of color furthering reproductive justice across the nation. They have excellent resources and webinars and trainings that your organization can sign up for to delve much more deeply into this topic than we've been able to cover today. The medical eligibility criteria for contraceptive use is really a clinical resource. This is sort of a World Health Organization and CDC based resource that allows you to understand the clinical safety of various contraceptive methods. And that's something that's available on a quick app on your phone where you can kind of look at which methods might be most safe for the patient in front of you based on their age, their smoking status, and any number of chronic diseases. And finally, Reproductive Health Access Project is a group that, similar to Bedsider, has a lot of important fact sheets, has great resources for clinicians, templates for your EMR. They really seek to infuse reproductive health into primary care so that it's not an other or a carved out service, but rather an integral part of the primary care that we provide to our patients. We want to acknowledge the myriad groups that support our work. We are a free clinic. We receive a lot of support from the College of Medicine here at the University of Florida, the Department of Community Health and Family Medicine, multiple different groups locally. We want to acknowledge the importance of the work of Sister Song, as they have really, their definition of reproductive justice has really been the guiding principle that we're basing our work on now. And we most importantly want to thank our patients. We've had our patients who share these like very intimate and important aspects of their lives with us that have humbled us in ways that really allow us to reflect and grow in the care that we provide for them. So we're ultimately very grateful to our patients. And we can now take questions. This is my contact information. If any of you have specific questions you want to follow up with, we'll have a Q&A session now. And although we have pre-recorded this session, both Kelly and I are going to be available for questions in real time during the webinar. And in the chat function, we will link to the reproductive justice webinar that we mentioned earlier. Thank you all so much for your time today.
Great, thank you all so much for that wonderful talk. Really inspiring work you're doing at the mobile clinic. For those that have joined us for this webinar, feel free to post some questions in the chat, which we have a few minutes here to try to address those. One of the first questions that came up, and I think one that a lot of us are asking and wondering is, kind of as you think about some of the low health literacy that you all identified regarding some of the contraceptive options, how do you work in education around those options as well as a potential same-day insertion or startup of a medication?
Yeah, thank you for this question. Certainly health literacy is something that is the foremost concern for us with our patient population, regardless of the issue. And I would say maybe the best approach that we've taken is just a multifaceted one. As I mentioned in the talk, we have these like laminated bedside or tiered contraceptive counseling sheets that provide a visualization of exactly what the method looks like and is a decent jumping off point. But then I think we just try to make sure that we're addressing literacy from multiple levels. So part of that are the health education materials that Kelly put together as part of her MPH program. Our team had really identified that there was a lot that goes on in the counseling about some of these methods, that there's just so much to take in that people would leave and kind of still have questions about it. And so we wanted to make sure that everything we talk about is in writing, and that there's also links to reputable sources that people can go to if they've had access to do so. Everything that we put together is in English and Spanish, and we do try to make sure that it's at a relatively low literacy rate that's recommended. But the other thing that's really important is just having like visual models that we do discuss. So in clinic, especially if we're talking about inserting something in the uterus or putting something in someone's arm, we have a lot of like tangible models and then written materials that I can show a patient exactly what that's going to look like. But what I'd like to say perhaps most importantly would be that same day insertion isn't necessarily right for everyone. It is our goal to eliminate like any of the barriers that would be on our side. We want to eliminate those for same day insertion. But absolutely, if a patient, you know, feels like they need to think about it or talk to a family member or research it more online, you know, whatever the case is, it's not something that we're pushy about. We just don't ever want the barrier to be on our side. So thank you for that question.
One of the questions I'm sure, and I certainly comes up for me, I have, you know, a busy primary care clinic, and the thought of, you know, somebody wanting a procedure or an IUD or some form of LARC inserted same day kind of makes me nervous thinking about how do you schedule that? Do you block time? You know, how do you manage that in a busy primary care clinic? And thoughts, I think, for people here that, you know, maybe trying to implement something similar in their practice.
Sure. And a little bit of context, like our clinic has traditionally been a hybrid model of some appointments when that works for a patient, but largely a walk-in clinic. So in other words, like starting the day and we're not really sure what exactly is going to be coming our way. That has shifted quite significantly in the era of COVID, just so that we can better plan for who's coming. All of that being said, you know, we do have a free clinic and we do have probably a lot more flexibility in adjusting to the day-to-day needs of our patients than, you know, maybe a more traditional clinic. But some of the things we talked about in the presentation, I think could be utilized in more traditional settings. So just things like having equipment that's already prepared and already put in a kit and is just ready to grab. And then having the support staff that's just been well trained and understands maybe the kind of quick need to adapt to a new situation and maybe able to be available there. So there, you know, just kind of different protocols or policies throughout the day that we can just make easier to be able to offer this same day. And those may differ by clinic. I will say, of course, the biggest barrier, at least in my clinic, that existed was just having the device. It wasn't so much that we couldn't like adapt to a new need for a patient, but rather we needed devices there. And we talked a little bit about how we were able to overcome that. I know that that's a big barrier in the world of health insurance. But I do think that there are some companies that make some of these devices that are, you know, are increasingly interested in helping to facilitate this kind of work. So if it's not something that's possible at your clinic yet, that might be on the horizon.
Another question that's come up is in terms to kind of student education. I know you've mentioned kind of this robust educational program for your care coordinators and your undergraduates in those roles. Can you speak to a lot of the students that may be in your clinic for a shorter period? Are there kind of dedicated time you spend on getting everyone up to speed on the idea of reproductive justice and this approach to care?
Also a great question. I think, you know, for better or for worse, probably the priority that we've made so far is training our undergraduate care coordinators. So I think that that's great to have that be a more robust program because they are with us, they commit to several semesters, and they're people that really, once that training is in place and they have some experience, can really give a lot of service to our patients. But yeah, as I mentioned, we have 4-week physician assistant rotations for our primary care and 2-week fourth-year medical school rotations that are an elective. And so this is absolutely something that's at the forefront of our minds, is making this more formalized. I will say up until this point, it's probably been a little more off the cuff. Like we see a lot of sexual reproductive health patients on certain days of the week. Word has just kind of gotten out. Those are our big reproductive health days. And so, you know, on case-by-case basis, we often do a lot of teaching related to this, but it's certainly something that's a priority for future work, is to make that more of a formalized aspect of our rotation.
Great. Last question that's come up. Would you all be willing to share some of the great resources you've put together? One that jumped out to me was the shared decision-making handout, which looks like a great tool that you might provide someone while they're waiting for an appointment, as well as I think some of the models that Kelly and Izzy have put together for education around kind of shared decision-making. I don't know if you'd be willing to share or at least let folks review those and have access to those.
Absolutely. I don't want to speak for Kelly, but yeah, I think it's our goal to make this open and accessible to anyone interested in doing this work. So absolutely, yes. Kelly, do you want to jump in?
Yeah, I would love to see these be available and used more widely. So anyone who's interested in them can definitely contact us and we will get that to you. Absolutely.
And Kelly actually did a lot of work getting us listed as a bedside provider. So, bedsider provider. Bedsider is the website we mentioned a couple of times, and they have a database of people that provide sexual and reproductive health services for low cost or free. And she worked really hard to get us listed in that database.
Great. Well, thank you both so much for your presentation. Thanks for all those that joined this afternoon and for your questions. If you'd like to receive continuing education credit for today's webinar, please make sure you fill out your evaluation of today's talk. And remember, September 18th, we'll have our next webinar on nursing and dentistry, a partnership for health. Everyone have a wonderful day. Stay safe. Thank you.
Thank you all so much.